Ευχαριστούμε. Ακολουθούμε αμέσως με τις ομιλίες των δύο visiting professors, Dr. Delfos, Professor Delfos and Professor Taylor. Professor Nicolien Delfos, MD, PhD, is a renowned pediatric ophthalmologist from the Netherlands. She is professor at the Leiden University and past president of the European Pediatric Ophthalmology Society. Παρακαλώ λίγο ησυχία. Professor Delfos has dedicated a large part of her career in the understanding and managing of retinopathy of prematurity. She has published numerous papers in peer-reviewed journals and has given a great number of lectures in Europe and around the world on the topic of ROP. It is indeed a great honor for us to welcome Dr. Delfos to Thessaloniki. Dr. Delfos.
Thank you very much for the introduction and for inviting me to talk about retinopathy of prematurity. Ladies and gentlemen. Wait, I have to find my name. Retinopathy, my lecture about retinopathy of prematurity will have a short introduction. We'll talk about classification, etiology, pathophysiology, treatment of not only with laser, but we will also cover some thoughts about anti-VEGF treatment, and we'll talk about screening.
Παρακαλώ προχωρήστε και φύγετε από την αίθουσα αν δεν θέλετε να καθίσετε. Για να αρχίσουμε.
No. I don't know what he's doing with it. Yeah. Retinopathy of prematurity, as we all know, is an abnormal development of retinal vessels in premature infants, especially those born under 32 weeks of gestation. Normally, retinal vessels start to grow from 16 weeks of gestation onwards, and the retina is fully vascularized at 36 weeks at the nasal part and at term at the temporal part. When you're born prematurely, you'll have incomplete vascularization, and you can see that as there is tapering of vessels near the avascular, near the avascular zone. Doesn't work. And the younger the infant, the larger the avascular zone will be. He's not very... The international classification for ROP was revised in 2005, and what they added by that time was a new zone, an addition to zone 2, that's posterior zone 2. You can see the zones in the picture. The first zone is the most central zone, and the posterior zone 2 is an additional zone, 3 times the distance between the center of the optic disc and the center of the macula. I don't, here's the pointer, yes, you can see it here. And then zone 2 ends at the nasal oral strata, and you have the crescent, which is zone 3. They also added one stage to the known classification of ROP. Of course, ROP1 shows the demarcation line, ROP2 the ridge. In ROP3 you get a broadening of the ridge and neovascularizations. Partial retinal detachment in stage 4, and when the macula is attached it's called a 4A, and if it's detached it's a 4B. Total retinal detachment in ROP5, and the newer stage they added was aggressive posterior ROP. And aggressive posterior ROP is specifically seen in children born under of 25 weeks or under, and it's located in zone 1 or posterior zone 2. It shows increased dilation and tortuosity in 4 quadrants, and it is not in concordance with peripheral changes we normally see. You don't see a ridge, you don't see a demarcation line. So if you see this picture, you might think that there's a large avascular zone, but for the rest everything is okay. But it's the contrary. You can have shunting circular vessels at the border of the avascular zone. Plus disease is becoming more and more important. It's increased arterial tortuosity and venous dilatation, at least in 2 quadrants in zone 1. And if you have a severe plus disease, there might also be iris rigidity due to dilation of iris vessels, and there might be a severe vitreous haze, so it's very difficult to see the fundus. It's a major criterion for treatment, and there's also a sort of warning sign, and it's called pre-plus disease, and you have increased tortuosity and dilation, but it's not enough for plus disease. And in the pictures, I don't know if you can see it good enough, but these are normal vessels. Here you see an increased tortuosity and a little bit of dilation, and here it's more severe, and that's the plus disease. ROP is a multifactorial disease. You see a list of risk factors for ROP, and it's just a short list. It's the most important ones. There are many more, but gestational age still is the most important risk factor. Oxygen and vascular growth factors play a key role in the development of ROP, and we are going to talk to that later. And of more recent interest is WinROP. It's something that came up from the Sweden Express study. It's an algorithm using weekly weight gain as a predictor for ROP, and if your weight gain is not good, you have an increased risk for ROP. When we are talking about pathophysiology, we have to talk about the two-phase theory. This is a picture from Mins Hittner from one of her publications. There are several factors influencing retinal vessel growth. They can be oxygen regulated, like vascular endothelial growth factor or EPO, or they can be produced by the placenta, IGF, and omega-3 fatty acids. And of course, when you are born too early, they will drop as you don't have a placenta anymore. The first phase of retinopathy of prematurity starts directly after premature birth. You will then the baby will then be in a hyperoxic environment, so the production of VEGF will drop, and there's a rest of vessel outgrowth. When you enter phase 2, when the retina develops and the child grows, the retina become relatively hypoxic, and then you'll have an increase in VEGF, and VEGF is one of the key factors in ROP. It's produced by the avascular areas of the retina, and when you have a hyperoxia, the VEGF decreases, and in case of hypoxia, you get an increase of VEGF. VEGF is necessary for normal outgrowth of vessels, but in the case of ROP, the production of VEGF is much too high, and then you will have neovascularization and a problem. Treatment is focused on increase of oxygen saturation, so higher target saturation, destruction of the avascular area that produces the VEGF by laser, and a decrease in the release of growth factor, and you can do that with anti-VEGF treatment. Quite recently, the results of the NEOPROM have been published. It's a prospective meta-analysis they did on patients included in the support boost studies and the Canadian oxygen trial, and they had nearly 5,000 infants under 28 weeks, and they looked at the target oxygen saturations until the age of 36 weeks postmenstrual age. And what they saw was if they would have keep the target saturation lower at 85 to 89%, you would have an increased risk for mortality, cerebral palsy, patent arterial ductus, apnea, and necrotizing enterocolitis. And if you would have a somewhat higher target saturation, 90 to 95%, you would have an increased risk for ROP and also for chronic lung disease. So we have a dilemma now, because the neonatologists, they want to have higher target saturations for all infants under 28 weeks until the age of 36 weeks, whereas we ophthalmologists, we like lower target saturations in the first phase of the ROP, and that's until 32 weeks of gestation. And we like the higher target saturations, of course, in the second phase. For now, the neonatologists decided to target their saturations at 90 to 95%. So we as ophthalmologists have the important task to monitor the incidence of severe ROP, because if that increases, we can go back to them and say that we want to discuss it again with them. But you also can use the higher target saturations. For example, in infants with pre-plus disease, with an increased tortuosity and dilation, you can increase your O2 saturation, for example, to 95 to 98%, and your VEGF will decrease. And you can do that when you are awaiting laser treatment, just to hope that your the disease will not progress. Or sometimes you can manage to prevent laser treatment, and the ROP will reverse. But you can only do that for a short period, and it means weeks, 1 or 2 weeks, because it also has a negative effect on the pulmonal development of the infant. When we are talking about laser, we are talking about diode laser. You distract the peripheral retina, so you will have less VEGF. There are good results when you use the ETROP criteria. There are reports about success for more than 95%. And of course, you will have a reduced visual field due to the scars that are that you can see here in the peripheral retina. What are these ETROP criteria? What you can see is that plus disease is really very important when deciding about treatment. You have to treat all infants with plus disease, and also the ROP3 in zone 1 children. There is some discussion about the children with ROP2 plus disease, because if the plus disease is not very severe, or the vessels have progressed quite a long way in zone 2, you can decide to carefully observe what you also do with all children who have an ROP1 or 2 in zone 1 without plus disease, or an ROP3 zone 2 also without plus disease. Of course, bevacizumab or Avastin is a subject of a lot of discussion in the world of pediatric ophthalmology and those treating infants with ROP. Mins Hittner did her study and showed that treatment of ROP3 plus in zone 1 might be beneficial, but there are many questions, and one is about the indications. Should we treat all children with plus disease in zone 1? Should we also treat children in zone 2? We don't know. What should be the right dosage? Even a dosage of 0.125 has been proven to give a good result. So, and what we have to keep in mind is that the premature baby is about 25% of the adult body mass. So there's also a lot of discussion about that. Then we have the timing, because there are also reports about infants who have been treated with bevacizumab and have had a retinal detachment within days or hours sometimes. You have to carefully look if there is any extraretinal fibrovascular reaction, or already is beginning retinal detachment, because that really is in the contraindication. There's a discussion if we should use it as a monotherapy or if we should add laser later on. You shouldn't treat with laser before you give the Avastin, because then you break up the blood-retinal barrier. There are worries about the systemic effects, because there's an increased plasma concentration up to more than 8 weeks after the injection. You will have decreased plasma concentrations of VEGF that might be needed for development of lungs or brain. And there are known late recurrences, long-term effects, and that means that we will have to take care of follow-up. These are late effects of the BDROP study from Mins Hittner, and you can see that there have been recurrences up to 70 weeks after treatment. And what you see is new vascularizations, not only at the former border, but also at the new border. You can see it with at the arrows. There have been a lot of complications after treatment with bevacizumab, which you can see here. And we talked about the crunch syndrome, that is the rapid retinal detachment, which you can get if you don't time very well. There have been recurrences reported after more than a year after treatment. What you see on fluorescein angiogram is that the larger vessels progress to the periphery, but there's no capillary meshwork, and it's thought that that creates peripheral ischemia and is a reason for recurrence. There has been one follow-up study published in the BGO from 20 eyes, follow-up 5 years, zone 1 and posterior zone 2 disease. They've had one-time bevacizumab. 11 of these 20 treated children had abnormal vessels or capillaries, and 9 of them had peripheral leakage at the fluorescein angiogram. And here you see images at 46 weeks, and there are also images from 86 weeks over here, and after 4 years here, and you see the avascularity in the peripheral retina. So there have been case series with favorable and unfavorable outcome. Laser treatment, you have to keep in mind that that has a good result following ETROP criteria. About the long-term effects, we know that there are recurrences after years. We don't know what the effect will be when they grow older, when we become adults. The effect on other organs. The company in USA has given a negative advice for treatment, and we obviously need more trials to make sure what we should do. Why do we screen? Well, we screen because we know that if we find the disease in time, then we can treat it. About half of the patients can develop ROP. Most resolve spontaneously, but some get severe problems. And if you look at the different screening criteria, you can see that they depend on national data mainly, and they are influenced by socioeconomic factors and local neonatal care. What we have in common is that we all screen children under 30 weeks or under 1,250 grams, but there are a lot of variable criteria for the children that are over these criteria, and mainly they depend on good clinical practice or the experience of the physician. And there are some recent publications that try to find a way in this good clinical practice and try to define somewhat more what infants in between 30 and 32 weeks or 1,250 and 1,500 grams should be screened. The first screening is still at 4 or 5 weeks postnatal age, but not before 31 weeks of postmenstrual age. Follow-up screening, of course, depends on the stage, if there's plus or not, and the zone. You should adjust your screening more frequently. You have to screen more frequently if there's rapid progression of ROP or an increased plus disease, and you can diminish your screening if you have several examinations showing regression, or if the child is 40 weeks PMA without ROP. There are pitfalls in screening. We did a large study in 2009, and we found that after transfer or discharge from the hospital, about 30% of infants was lost to follow-up. And one of the issues was that often the ophthalmologist is not notified, so the children are not screened at all. And one of the important other factors, and it might be useful for others to think about that, was that the instructions for follow-up were not clear. If the child is transferred and the neonatologist writes in his letter what you've seen as an ophthalmologist and then says the child has to be revised in 2 weeks, but the examination was two weeks before, and the child is transferred actually around the time that he should be rescheduled for screening, then he is transferred to the other hospital and they think, oh, we have to screen it in 2 weeks. And that really was one of the things that came out of this study. And in our new guideline, we say that you have to mark a date or at least the week that you want to next screening. How can you screen? You can screen by indirect ophthalmoscopy. Then you draw your reports or you write them in an electronic patient device. Your comparison of your follow-up examinations, of course, is subjective. Your interpretation is very personal. If others take over, they might have another view. And also there's an issue when you transfer your infant to another hospital. And it might cause a lot of transportation from infants up and down to more experienced ophthalmologists. If you screen with a camera, you have digital images. It can be done by a nurse or physician assistant. There have been lots of other examples of that. Your comparison of data is objective. It's easy to ask an expert opinion without transportation of the infants. You can use your mail. The timing of treatment can be much more exact. And of course, the most used for this imaging is the RedCam. However, there are severe obstacles for this digital imaging, and the most important probably is the pricing of the camera, which is at around 130,000 euros. The number of infants per hospital with severe RP mostly is small. The rate paid by the insurance company is usually marginal. I don't know how it's here, but in our country it's not much. And the cost effectiveness studies are not widely available and may differ per country. There are some other cameras coming on the market, so there are people looking for better solutions, but most of them still are expensive. They are not all easy to handle, and there might be quality issues. You can make pictures with your iPhone and a lens, but it's very difficult to compare them when you do it again a week later. We had a special project in the Netherlands, and it was based on our national survey in 2009, the NetDrop study, which included all infants fulfilling the screening criteria at that moment. And we had a complete data set at the end of the study of 83% with all neonatal data. One of the outcomes was that the screening had shifted from the screening in NICU hospitals to mostly high care centers, because infants are transferred earlier, because they have to make space for the more severe ill infants in the NICUs. And in this study in our country, 17 of 30 infants with severe RP happened to be not treated. We were very shocked about that because we thought we did it very well. And 3 of these 17 infants even developed an end stage of ROP. So that we had an awakening call that we should do it better. And we had RedCams, but we didn't have them in the high care center. We only had them in a NICU center. So we thought that we should do something about it. And what we did, we involved the Queen, we involved the parents of the premature infants, and we interested the zip code lottery. And what they did, they earned a lot of money, and now we have 10 RedCams for high care centers. And we installed a reading center where people can send their pictures to if they want to have them reviewed. And of course, it's not the way you can do it in every country, but we thought we wouldn't manage to do something like that, but just we started it up. So sometimes you can just be brave and try to organize something for the patients you want to treat. Well, I hope I've shown to you that RP is an exciting and challenging subject. There are ongoing developments, and as ophthalmologists, we have to keep up to date. We have to monitor our outcomes. We have to communicate with neonatologists, and we have to involve the parents. And at the end of my presentation, I would also point out to you, would like to point out the annual meeting of the EPOS, which will be in Barcelona. Nicolas Jacas is our president. He will be glad if we come all, I think. It's about pediatric cataract and glaucoma, and participants under 35 years of age, they can apply for travel grants or for best presentations awards to cover the costs. Thank you very much.
Thank you, Dr. Delfos, for this truly amazing presentation. And I would like the audience, if there are any questions. If there are no questions, I would like to ask one. Have you tried IGF-1 for the first phase or propranolol for the second phase? There are some reports that they may be beneficial.
Yeah, well, the IGF we do use, and we have the idea that's beneficial, but it has to be proven in larger studies. Right. We didn't try the propranolol yet. There's a study underway in the States where they are treating infants with that, but we wait their results because it also has other side effects to the infants.
The first
of course.
One with the 52 infants, 1 out of 4 had to be resuscitated. I guess the dose has to be adjusted.
Yeah, so we are I'm very careful with that.
Yes,
I just wait a bit.
Of course. I was just wondering. And then I agree with you entirely that we need good phase 1 studies and 2, because whatever works in the lab or in animals does not necessarily is not necessarily translated to beneficial effects for humans. And the best example of that was the STOP ROP study. Yeah. We know that in phase 2 we have hypoxia. Of course, why not to give oxygen during that phase? Mm-hmm. And when it worked in animals, and when they tried that in the 90s in the US, it was not beneficial. It made no difference whatever in the ROP. Yeah. So
no, I agree. I know that there is a trial underway in the US, and they are also trying to start up something in Europe to work with different countries, because of course you have to have enough patients to treat, and that's a problem because we're all small countries, and we all don't have enough body. Actually,
we need multi-center studies.
Well, we have to do it together.
Well, it was an honor. Thank you so much for coming. Our next speaker is Professor David Taylor. Please allow me to reintroduce Dr. Taylor formally.